The Senate Committee on Banking, Housing, and Urban Affairs will come to order. Today's hearing is a hybrid format. Our witnesses will testify in person. Thanks to all 5 of you for making the effort to be here. Some of you came as far as from Cleveland, so thank you for that. The members will participate, some in person, some virtually. Think about watching a loved one rush to the hospital in an ambulance, or learning you have a chronic disease that's going to require years of care and monitoring. These kinds of medical ordeals are some of the scariest moments in a family's life. They can happen at any time to anyone without warning. Suddenly you're coordinating doctor's visits and calls with insurance companies. You're nervously checking your savings account. You're spending hours on interminable phone calls trying to get answers. You're dealing with it all while worrying whether your husband or your mother or your child will make it out of the hospital and whether their health problems will continue. As the cost of prescription drugs rise, hospital bills skyrocket, debt collectors start calling, families are forced to figure out how to make ends meet instead of focusing on their health. Families all over the country are telling us that. We heard from Penelope Wingard, an after-school teacher from North Carolina who lost her health coverage while battling breast cancer. When her medical bills began to pile up, her doctors eventually stopped seeing her. Soon after, she had an aneurysm in addition to vision loss. Both required surgery. Because of the financial situation caused by her diagnosis, Ms. Wingard was forced to wait and then seek care from a limited list of providers who were allowing sliding scale payments. Debt collectors call her. They harass her every single day. Now her credit's ruined because of her health. Right now, Ms. Wingard needs additional testing to ensure her cancer is not returned, which has added an additional $2,000 to her debt. So instead of focusing on battling her illness, she has to figure out how to handle debt collectors. Ms. Wingard is far from alone. In the United States, 43 million Americans hold $88 billion of medical debt on their credit reports, and this problem is growing. It can happen to anyone: low-income families, Black and Hispanic households, veterans, young adults, and older adults are hit particularly hard. Debt collectors make this already exhausting experience worse. They call over and over, they make threats, they even contact patients' employers. Take, for example, Mindy Hedges from Delaware County, Ohio. She's had type 1 diabetes since she was 5. For most of her adult life, until the passage of the Affordable Care Act, she was unable to get health insurance because she had a pre-existing condition. After losing her business in the 2008 recession, her medical bills piled up. She was unable to repay them. That's when the debt collectors started calling and calling and calling and calling. Ms. Hedges did her best. She tried to negotiate. She even begged for relief, but the harassment continued. At one point, she said she was even afraid to leave her house. This harassment is part of the business model. A counselor at a medical debt collection agency owned by a private equity firm had some choice words about harassing patients. They said they found the first 20 to 30 calls to be, quote, highly effective. If the calls don't work, debt collectors often move on or to even more aggressive tactics like litigation, forcing people to go through lengthy, expensive, emotionally draining court proceedings, often while still battling cancer or grieving a loved one. For patients, litigation can result in garnished wages or property liens. We've seen people thrown in jail because they couldn't afford to pay. It's the return of debtor's prison. People in the United States of America, Matt, think of that, today are in jail right now because of medical debt. Of course, whenever we find suffering, Wall Street finds opportunity. Private equity firms are making inroads in the medical debt collection market. Between 2015 and 16, 1/3 of all debt collection agency acquisitions were bought by private equity. Those firms exist clearly to maximize investor profits, no matter the cost to society. Maybe that's why private equity-owned debt collection agencies are responsible for an outsized number of consumer complaints, many concerning attempts to collect debt from people who do not owe them. We must address the growing crisis of medical debt burdening American families. President Biden and his administration are working to remove barriers to medical debt forgiveness for veterans and to make it easier and cheaper for them to get care. No one who served this country should be saddled with debt for illness or injuries incurred in the line of duty. The Biden administration wasted no time in implementing the No Surprises Act, which took effect on January 1st. The bipartisan law finally bans surprise medical bills One way to prevent debt collection harassment is to protect people from debt in the first place. The CFPB is also doing important work exposing abuses Americans face while just trying to get health care. And after increasing scrutiny and pressure, the three credit reporting agencies, Equifax, Experian, TransUnion, all announced they would significantly change how medical debt collection debt is reported. These changes are expected to remove nearly 70% of medical debt in collections from credit reports. It's a positive first step, but just a step. This first step gets to a basic fact that we too often ignore. Medical debt does not correlate with credit risk. It correlates with illness. It should be obvious anyone can get sick, anyone can get in a car accident. It doesn't have anything to do with your ability to pay your bills, or at least it shouldn't. No one should be forced into poverty. No one should be harassed by shady debt collectors because of a medical emergency or a sick family member. We've taken important steps to protect Americans, but we can do more. I'm asking the CFPB to create an ombudsman position for consumer medical debt. It's also why expanding Medicaid coverage to those who live in the 12 states that have refused to expand Medicaid under the Affordable Care Act is long overdue. I'm appreciative of two members of this committee, Senators Warnock and Ossoff, who are working to finally get this done either here or in their state. Of course, meeting these challenges can't be done by government alone. Private industry must act. This country needs private institutions to meet their obligations of financial assistance in the No Surprise Act. We're hearing from two advocates for consumers as well as one of my constituents, Robin King from Cleveland. Ms. King will tell her story of battling medical debt she never owed after a nursing home cared for her mother. I look forward to hearing more about how we can protect Americans from medical debt and debt collector harassment. No one should have their financial future ruined simply because they got sick. Senator Toomey.
Thank you, Mr. Chairman. Pricing risk accurately is critical to the safety and soundness of financial institutions and to consumers' ability to access affordable credit. Because when borrowers default, lenders have to absorb the costs. And that's why lenders generally look at information about credit history. It helps them estimate the risk of default and to price loans. Lenders who cannot access information that they consider predictive of risk are likely to restrict their lending to the borrowers with the thickest credit files, seek out relevant proxies for the credit information they are not able to obtain, or increase the price of loans to all borrowers in order to capture the uncertainty and the risk. This hurts all consumers, especially low-income families and those with a long credit history. For all those reasons, the government should not suppress the reporting of accurate credit information. Unfortunately, so-called consumer groups and allies have sought to remove information from credit reports and thereby make them less accurate. I'm afraid such actions will have adverse unintended consequences. Today's hearing is titled, quote, "Growing Burden of Medical Debt," end quote. It's an interesting but inaccurate title because evidence suggests that medical debt is actually falling, not growing. According to the CFPB's own estimate, which the chairman cited, medical debt in collections last year was $88 billion. That's a nominal reduction of 10% over the last 3.5 years. Another study showed that the average medical debt in collection fell by 40% in the last decade. And that's despite the fact that over the same period, medical spending increased by 70%, and over 50% per capita. This is all illustrated on Chart 1 behind me. Now, there are likely many reasons for a decline in medical debt. A primary driver was the improving economy. After the tax reform of 2017, those with the lowest wages, those most likely to have medical debt, were making the biggest gains in income. Another driver of the decline was the enactment of Obamacare and Medicaid expansion. Researchers estimate that for every $25 spent on Medicaid expansion, medical debt in collections decreased by $1. Now, there are many aspects that have made me question the wisdom and efficacy of Medicaid expansion, including its cost and the lack of evidence that it improved healthcare outcomes. But unsurprisingly, if you're willing to spend massive amounts of other people's money, you can transfer individuals' debts onto the taxpayer. That's illustrated in chart number 2. So all available evidence suggests that there is no growing burden of medical debt. In fact, the scale of medical debt is often misunderstood. As chart 3 illustrates, medical debt in collection represents less than 1% of all household debts. 2/3 of medical debt collections are under $500. And bankruptcy from medical debt is extremely rare, as illustrated in Chart 4. 0.03% of the population suffers bankruptcy each year as a result of a hospitalization. And medical debt is not strictly an American phenomenon. Every healthcare system in the developed world includes some out-of-pocket payments. According to the World Health Organization, even before Medicaid expansion, the likelihood that out-of-pocket expenses would exceed a quarter of one's income was roughly as rare in the United States, 0.8%, as Canada or the UK, about 0.5%, and considerably rarer than in Italy, Spain, Korea, Switzerland, and other countries in the developed world. Recently, credit reporting agencies announced changes that will reduce the amount of medical debt that appears on consumer credit reports going forward. Now, if a credit reporting agency decides to exclude this information, I don't think it's the government's role to meddle with that decision. However, if credit reporting agencies had collectively decided the opposite, if every one of them had gotten together and they decided they'd begin at the same time to add consumers' medical debt information onto reports, I suspect the howls and protests about greed and collusion would have been deafening. What appears to have occurred here is that a political campaign, which included the CFPB, bullied lenders and credit rating agencies into removing this information. This kind of misuse of power by the administrative state has grown all too common. It's an example of how Congress has become far too comfortable with the executive branch seizing the Article I lawmaking authority of Congress. We need to be careful that any actions considered to address symptoms, in this case, debt from a health condition, don't make matters worse. This new credit reporting agency policy doesn't actually lower the cost of medical care. In fact, it'll either raise costs or reduce access. It may end up discouraging people from paying medical bills. That could lead to healthcare providers finding ways not to treat individuals without an obvious means to pay. And by eliminating one metric in a credit rating, it may cause credit rating agencies, to use other metrics or proxies that are less accurate and which could actually hurt low-income populations more. These kinds of downstream effects wouldn't be shocking, given that the entire effort to micromanage credit ratings is coming from an agency that has no expertise on complex medical billing and healthcare systems. It should remind us that intervention into the market, no matter how noble advocates may think they're being, will have consequences, usually unintended consequences. And second, intervention should come after careful deliberation by the people's representatives, not diktats from unelected bureaucrats. Thank you, Mr. Chairman.
Thank you, Senator Toomey. I'll introduce today's 5 witnesses. Robin King, a former second-grade teacher's assistant in Cleveland, now works part-time and volunteers when she's not caring for her family. Ms. King uses her voice to shed light on the terrible toll that medical debt is taking on average Americans. Emily Stewart is the executive director of Community, overseeing the direction of its advocacy of consumer health care rights in the organization's finances and operations. She has 2 decades of experience in healthcare advocacy. Dr. Benedict Ippolito studies healthcare financing, the pharmaceutical market and its regulations, and the effect of healthcare costs on the personal finances of Americans. He's a senior fellow in economic policy studies at the American Enterprise Institute. David Hyman is the Scott Ginsberg Professor of Health Law and Policy at Georgetown and is an adjunct scholar at the Cato Institute, a doctor as well as a lawyer. He served most recently as the Ross and Helen Workman Chair in Law and Professor of Medicine at the University of Illinois. Bernetta Haynes is a staff attorney at the National Consumer Law Center, working on a portfolio that includes consumer medical debt policy and energy policy. She recently published a report examining the intersection between the racial health gap and the racial wealth gap and the harm of aggressive medical debt collection. Thank you all for giving us your time and joining us today. I'll begin with Ms. King. Welcome.
Good morning. It's an honor to be here today and a privilege to be able to share my story with this committee. I'm here to speak about my experience with medical debt. It's something that affects thousands and thousands of people in this country every year, and I know firsthand that the consequences of these burdens can be debilitating. I was lucky enough to get help from attorneys at Legal Aid in Cleveland, but many people are not so lucky. For them and for others who have yet to be victimized, I share my story. I'm a mother of 3 children. I worked as a teacher's assistant for 10 years and recently transitioned to working part-time at a learning center. I still volunteer with children and older adults in my spare time. I also am the youngest of 6 siblings who all care deeply about our mom. If you've ever brought a parent or loved one to a nursing home knowing that they will live out their final days there, knowing you are trusting all of their care and comfort to strangers, that's a day you'll never forget. Because Mom was suffering from Alzheimer's and had difficulty understanding what was happening, my siblings and I decided I would be Mom's representative for the nursing home admission and sign all the paperwork that allowed my mom to be admitted into the facility. Mom's Social Security checks were used to pay for her portion of the nursing home bill, and Medicaid covered the rest. Knowing my finances were already tight, I made sure to check the box on the nursing home admission form which said I did not agree to be personally liable if finances for my mom's medical care ran out. I have a household of my own to take care of, and I knew I couldn't afford to pay any nursing home for my mom's medical expenses. In November 2019, the nursing home staff told me my mom's Medicaid needed to be reinstated. So I went to the office and filled out some more forms. I didn't hear anything from them about Medicaid for months, so I assumed that everything had been taken care of. I was shocked when the nursing home told me in May 2020 that mom's Medicaid had not been reapproved and that I was now responsible for paying a huge bill. Why hadn't they told me this months ago? How could they have kept this information from me when I always did everything the nursing home asked me to do? Maybe we could have figured out a way to prevent them from coming after me for this debt. Because the nursing home took so long to tell me that Medicaid had stopped paying mom's bills, the amount owed had grown huge. They were now trying to collect almost $70,000, and while I tried frantically to fix the situation, the nursing home started sending bills each month, every bill larger than the last. My mom passed away on October 3rd, 2020. Just 2 days earlier, I had received notice that I was being sued by the nursing home for close to $80,000. I never had time to grieve. I kept so much inside, the stress was unbearable. I thought I won't be able to fix my mortgage, afford my mortgage. I am definitely going to lose my house. I could face a garnishment of my paycheck and be forced to live on a reduced income when money was already tight to begin with. What will I tell my kids? What does it mean to have this kind of judgment against you? How will that impact the rest of my life? At one point, I even thought I'd rather be with my mom. I felt defeated. I had nothing to give. The lawsuit made no sense to me since I told the nursing home that I would not be personally responsible for any of my mom's medical expenses. On my sister's advice, we called Cleveland Legal Aid. I am so grateful for my attorney's help because they freed me from having to pay the nursing home debt with my own money. The nursing home is still pursuing my mom's estate for what is owed, so it's still impacting my life. While I'm not personally on the hook for the debt, they're still going after my family's assets. I hope you can take action to protect people like me and not allow medical debt to upend people's lives. Medical care is not something we can opt out of. Getting sick or having a family member get sick should not force people to face crushing amounts of debt. I thought I'd done everything right in taking care of my mom, but without Cleveland Legal Aid, I would have had an enormous judgment against me, and my family's financial future would have been devastated. There must be a better way to take care of each other and not leave people like me facing life-changing amounts of debt. There's just no excuse for this in America. I hope that my testimony today will help you turn my story into something positive. Thank you.
Thank you, Ms. King. Ms. Stewart of Community Catalyst, welcome.
Thank you. Good morning, Chairman Brown and Ranking Member Toomey and members of the committee. Thank you for having me. Community Catalyst is a national nonprofit organization that is dedicated to building the power of people, to build a health system that is rooted in race equity and health justice in a society where health is a right for all. For nearly 25 years, we have worked at the forefront of local, state, and national conversations to make the health system more responsive to people. And over the course of that time, one of the major takeaways from our work has been the deep connection and troublesome connection between people's health and their overall financial well-being. There's no issue that science shines a brighter light on this reality than the issue of medical debt. It's important to put medical debt into its context. Our health system is costly, it's imbued with inequity, and this harms us all. Billing and collection is complicated and confusing, even to experts, but it's patients, individual people, who are put in the position of resolving that complexity, whether it being figuring out whether or not they owed the bill to begin with, or navigating a dispute between their health plan and their healthcare provider. There are many sources of medical debt, with the largest share from ER visits, dental care, and diagnostic tests, such as x-rays and MRIs. It is such a concerning issue that 40% of Americans say that they are more fearful of medical debt than a serious illness. The Census Bureau estimates that 17% of U.S. households hold medical debt. There are other studies that have higher estimates, and it is entirely plausible that the most people know someone who has been impacted. In preparation of this hearing, I decided to survey my siblings. I have 7 of them. 5 of us have had medical debt in the thousands, ranging from ER visits, pregnancy-related care, and surprise bills. Of course, medical debt impacts some more than others. People who are uninsured are more likely to have medical debt, and importantly, many of them are living in states that have not expanded Medicaid under the Affordable Care Act. And due to discriminatory barriers to affordable coverage and care, there's a disproportionate effect on people of color, with 27% of Black households and just under 19% of Latinx households reporting medical debt. Families with children are far more likely to have medical debt than those without, and families with a member who has a disability are nearly twice as likely to have medical debt. Medical debt can have a profound impact on people's health and well-being. 37% of people with medical debt have used up all their savings to pay off their bills. 31% took on new credit card debt, and 11% took out a mortgage against their income or another type of loan. People report reduced spending on food, clothing, and other household items. It should come as no surprise that people with medical debt are much more likely to report experiencing stress, anxiety, and depression. And the COVID-19 pandemic has exacerbated the issue for many. For example, through our work with coalition partners in Illinois, a story was surfaced of a man with work authorization in the state. He was rushed to the emergency room with COVID-19 complications and subsequently charged $11,798. The hospital denied him any financial assistance, even though he was eligible under state law, and even though federal assistance was already in place for COVID-19 related care. He paid over $1,000 each month for a number of months because he was afraid that his bill would impact his immigration status or his ability to buy a home. Whether a person's medical bill problem is alleviated or aggravated hinges on who holds the debt. Many hospitals offer extended payment plans directly to their patients, and in fact, nonprofit hospitals are required to offer financial assistance under federal community benefit standards. However, many people are unaware of these programs and not adequately informed upon them upon receiving their first bill. For many people, the headache begins when the bills are sent to third-party collection agencies. These agencies are paid a percentage of the debt they collect. They typically report the accounts to the credit bureaus, and if not paid promptly, they pursue legal action. Numerous press reports have detailed people having their wages garnished, bank accounts frozen, or liens put on their homes. Medical debt can ruin people's credit rating. And to make matters worse, the data is often inaccurate or out of date. An analysis by CFPB showed that nearly 2/3 of collection complaints assert that the debt was never owed, never verified as a consumer's debt, already paid, or discharged in bankruptcy. Proposals to address this issue are necessarily multifaceted, but there are a few to highlight. Senator Brown, Community Catalyst, supports your proposal for a CFP ombudsman to resolve medical debt complaints. It's important to also eliminate unpaid medical billing data on credit reports and to hold credit reporting agencies accountable for accurate data. It's important also to strengthen nonprofit community benefit standards, to prohibit wage garnishments and liens on property, and to apply those protections to for-profit hospitals. Also, extending Medicaid coverage to people who are living in states that have yet to expand Medicaid. Thank you for hearing this testimony and look forward to your questions.
Thank you, Ms. Stewart. Dr. Ippolito.
Well, thank you very much for having me. I'm going to echo some of the comments that we just heard. Medical debt is different than other forms of consumer debt. A lot of consumers aren't actively pursuing this debt. They're not taking on debt intentionally. And more than that, I think it reflects these features of the healthcare system that attract justifiable criticism. It's very expensive. Billing is quite complex. And so certainly the extra attention that we pay to medical debt is certainly understandable. That said, as policymakers consider the issue, it's important to begin with a firm grasp of the empirical reality surrounding medical debt in the United States. I think many of us think of medical debts as reflecting tail events, those kind of unexpected catastrophic health shocks that can give rise to very large bills. And while those debts absolutely do exist, they do not, when you look at the data, appear to be representative of the typical experience in the U.S. Instead, medical debt is a very common phenomenon that seems to reflect actually much more typical common interactions with the healthcare system. So for example, About 16 or 17% of adult Americans have medical collections on their credit reports. The average medical collection itself is about $300. I think for a lot of people that's relatively modest, and I don't mean modest in the sense that that's unimportant, modest in the sense of the kind of bills that we know can happen in the healthcare system, certainly that we heard about today. In aggregate, consumers owe about $100 billion in medical collections alone. That number is a little higher if we include other forms of medical debt. About 92% of those medical collections, however, are never reported as paid on credit reports. These debts can affect household finances in a few ways. Perhaps most centrally, they can lower credit scores. That obviously makes it harder or more expensive for consumers to borrow. Many have called that practice into question, so it's worth considering what policy changes are warranted and what trade-offs we might need to consider. Obviously, credit scores are meant to summarize credit worthiness, so if they aren't doing that accurately, if they're penalizing consumers for things they can't control or otherwise are not predictive of their credit worthiness, those are kind of things we ought to address. And I think some medical debts clearly fit in that category. So for example, a medical debt that's initially incurred because of confusion over a billing process, but is later repaid, surely carries less predictive risk about future credit risk than a bill that is willingly incurred and then goes unpaid for a long time. So policies that, for example, would distinguish between things like paid versus unpaid medical collections certainly would help consumers who are inappropriately penalized in the current market. Some obviously argue in favor of policies that go further and disallow the reporting of otherwise accurate medical collections. Indeed, the major credit bureaus have announced a policy that would do that for the majority of medical collections recently. Those kind of policies come with more potential unintended consequences that I do think are at least important to flag for policymakers who are interested in this area and are interested in these policies actually achieving their stated goals. So in particular, while medical collections are certainly less predictive of some future repayment risk, that does not mean they are not predictive. And so we have to think about, from the perspective of a lender, there's a risk that they place some value on that is now not eliminated, it's obscured. So how are they going to respond to the fact that they cannot observe this anymore? And so I think there are a couple potential ways. So first, you might try and reweight. You might try and put more emphasis on other kinds of things that appear on credit records that aren't medical collections, but you think are indicative of a similar risk. Other kinds of collections, other kinds of delinquencies, for example. It is not ex ante obvious that the distributional consequences of that kind of reaction are better than the status quo. If they don't think they can find a clear proxy, they may instead just increase the cost of borrowing across all consumers, or in some cases, you may change your lending habits, particularly in populations where you think there is a high unobserved risk and where it's harder to proxy. So for example, young consumers carry a lot of medical debt in the United States. They also tend to have thinner credit files. That's the kind of population where you may be more concerned about that kind of adverse reaction. Finally, these trade-offs, I think, sound a little bit academic or theoretical, but they're certainly reminiscent of very real-world issues that we see certainly in the healthcare market, where we try and achieve similar things through regulatory redistribution. So, for example, health insurance premiums can't vary with health status or expected health expenditures. That obviously is motivated by equity concerns, and it has a similar flavor to what we're talking about today. We're trying to help people who have this unexpected health shock that they can't necessarily prevent. That said, it distorts pricing signals in the market and it creates a lot of instability. We constantly have to be vigilant over risk pooling issues in these markets. We constantly have to be vigilant about unraveling incentives that distort the actual stability of the fundamental market itself. If the market isn't stable, if we don't have insurance products that are readily available to consumers, that really attenuates the benefit of a lot of these policies. And so that's not to say this is an important topic and it's not worth addressing. It is to say, however, that there are important potential unintended consequences that we should be aware of and we certainly should emphasize. So I thank you for having me. I look forward to the questions.
Thank you, Dr. Polito. Professor Hyman.
Chairman Brown and Ranking Member Toomey and other members of the committee, thank you for inviting me to speak to you. I'm a professor at Georgetown where, among other classes, I teach consumer protection in a course entitled How to Regulate. So this is very much something I think about a lot. I'm primarily a health law and policy person. I've also been the victim of identity theft and had to deal with medical bills for myself and my kids. So I think the difficulty of going forth when we've got such a distinguished lineup of speakers is to say, well, a lot of what I wanted to say has been said already, so I'll focus on a couple of issues that have not been flagged yet. The first is you hear numbers thrown around, and those numbers vary widely, right? We've already heard figures ranging from $89 billion to $195 billion in medical debt. when you see a range that wide, you should conclude that there's some uncertainty as well as variation in the way in which people are measuring things, and that's exactly what's going on here. Methodological choices and definitional uncertainty matter. So the most common approach to quantifying the problem of unpaid medical debt involves looking at credit reports, and those credit reports flag certain things as coming from medical providers that are in collections. Now, that's a series of limitations that you ought to at least be aware of, right? Because most of these studies involve data from a single credit reporting agency, and the same information is not necessarily reported to all of the agencies. Second, the accounts that are in collections are necessarily a subset of all accounts, particularly given the time lag in reporting. But the additional problem that's often not appreciated is the designation of medical debt obscures the reality that patients often use a variety of strategies to pay for their healthcare bills, including paying for using traditional credit cards, using medical credit cards, taking out home equity loans. And if those go into collections, even though they're attributable to an underlying medical cost, they won't be flagged as medical debt. And the alternative approach uses surveys, including data gathered by the census, that has some advantages and some disadvantages I'm happy to talk about in the Q&A. But the short version is the numbers that you hear reflect a very specific set of assumptions about what does and doesn't count as medical debt. The second point I want to make is that medical debt is a function or a result of multiple interactive factors. You can start with whether somebody receives health care or not. Second, how much they are billed for it. Third, how much is paid for or discounted off of that list price from various sources, and that includes insurance, it includes self-payment, it includes charity care policies, and all of those are moving parts that affect whether any given individual with any given set of circumstances has medical debt, and if so, how much. The third point I want to make is that modifications to credit reporting of medical debt may provide some relief, but as Dr. Ippolito already said, you should be wary of some of the unintended consequences. It's a solution to a symptom. It's not a solution to the underlying problem. And that's the last point I want to end with and emphasize, which is the reason why we have medical debt is because healthcare in the United States is expensive. And if you want to address the problem of medical debt, you should treat the underlying cause, i.e. the disease, rather than the symptom, and focus on ways of making healthcare less expensive. I flagged two possible strategies, but there are many others, one of which is pushing hospitals to more fully implement their charity care obligations, specifically nonprofit hospitals, which have long had an obligation to do that under both state and now federal law. I think to the extent hospitals are a major source of these bills that result in medical debt, that's going to be an important tool that already exists. Second, I want to acknowledge that Congress has already taken an important step in addressing some aspects of medical debt with the No Surprises Act that both Dr. Ippolito and I helped consult on in the context of that legislation. And there are additional strategies as well, but it's important to keep your eye on the ball. The ball here is high healthcare costs that result in these problems, and those problems are disproportionately borne by certain portions of the population. Thank you very much for your attention.
Thank you, Professor Hyman. Ms. Haynes, welcome.
Chairman Brown, Senator Toomey, members of the committee, I appreciate the opportunity to testify on the economic impact of medical debt. I provide my testimony today on behalf of the low-income clients of the National Consumer Law Center. We believe medical debt poses a severe problem disproportionately impacting Black and Latina families. We ask that you provide consumer protections to prevent medical debt at the outset and to shield consumers from harmful debt collection practices and long-term impacts on their well-being. According to the CFPB, medical debt represents more than half of all debts in collection and remains a leading cause of bankruptcy. I live in Georgia, where I've worked directly with consumers and seen up close the real-life impacts of the medical debt crisis. 19% of Georgians have medical debt in collection, 17% of white Georgians, and 21% of non-white Georgians. Likewise, 17% of Ohioans have medical debt in collection. 17% of white Ohioans, 23% of non-white Ohioans. Similar disparities exist across the country. Consumers with medical debt face aggressive debt collection. To avoid debt collection, families drain their savings, increase their credit card debt. They turn to deceptive financial products like medical credit cards and high-interest loans to pay off medical bills. Because medical debt often appears as other forms of debt in individual credit history, it likely has an even larger impact than data currently shows. Aggressive debt collection takes so many forms. Hospitals sometimes turn bills over to third-party debt collectors who may use frequent, abusive, and harassing communication to pressure consumers to pay. Medical debt is consistently the most common type of debt about which people are contacted by debt collectors. Debt collectors contact Black households at twice the rate of white households, according to the FTC. In some cases, healthcare providers, hospitals, and debt collectors file lawsuits against the consumer. They may use these lawsuits to seek liens against homes, garnish wages and tax refunds, seize bank accounts, and even seek civil arrest warrants when the debtor fails to appear for proceedings. Between 2009 and 2018, hospitals in Maryland filed nearly 40,000 lawsuits that resulted in wage garnishment, often from their own employees, according to National Nurses United. Johns Hopkins alone sought over $4 million in wage garnishment lawsuits between 2009 and 2018. It has a service area that is 45% Black. The University of Virginia hospital system has a history of relying on property liens to collect unpaid medical bills, as Kaiser Health News reported in 2020. As a result of that expose, the system canceled decades of liens placed on low-income patients. VCU Medical Center in Richmond, a majority Black city, filed the most lawsuits of any single hospital from 2018 to 2020, according to researchers from Johns Hopkins. Worse yet, the ACLU documented cases of arrest for medical debts in several states, including Maryland, Tennessee, and Arkansas. In Maryland, they observed the practice of patients being jailed for medical debts of less than $1,000. The result of these practices essentially revives debtors' prisons, which should be illegal in this country. These debt collection tactics, for obvious reasons, stir up fear in consumers, harming not only their financial well-being, but also their physical and psychological well-being. Consumers may forego or delay medical care because they fear medical debt, which can harm their physical health and lead to greater medical expenses in the future. Carrying debt and being subjected to these debt collection practices also causes psychological distress, increasing anxiety, depression, substance use disorders, and other mental health disorders. All these things can lead to greater medical bills and debt down the road, a vicious cycle. So to address this epidemic of medical debt, we ask that you focus on ways to prevent medical debt so that seeking health care doesn't send individuals into a financial tailspin. We ask that you consider consumer protections that address the racial disparities in medical debt. Ban wage garnishment, bank account seizure, property liens, foreclosure of homes based on medical debt liens, and civil arrest warrants for medical debt. Prohibit debt collection during health insurance appeals, in the practice of turning over medical debt to third-party collectors. Prohibit providers and debt collectors from reporting all medical debt to credit reporting bureaus. Enact a universal, publicly funded national single-payer health plan administered at the state and local levels. There is more detail on these recommendations found in my written testimony. I do thank you for the opportunity to testify, and I'd love to answer any questions you have.
We will begin the questioning with Senator Warnock, who's been advocating for Medicaid expansion, and Ms. Haynes State, as she knows. So, Senator Warnock, you're recognized.
Thank you so very much, and it's good to see all of our witnesses, particularly Ms. Haynes from Georgia. And thank you, Mr. Chairman, for letting me go early due to my presiding obligations. The Affordable Care Act allowed states to expand Medicaid to over 13 million Americans. This is transformational legislation for our country, but sadly there are still 646,000 Georgians unable to access free and affordable health care because state politicians continue to prioritize politics over people. I've been fighting for Medicaid expansion long before I came to the Senate, And when I arrived, I fought really hard to get further incentives for Georgia to expand Medicaid, which we won in the American Rescue Plan, and the state continues, state politicians continue to refuse to expand Medicaid, a net loss to the state and certainly to the 646,000 Georgians in the Medicaid gap. And that's why after that, I introduced the Medicaid Saves Lives Act, which would give folks in states like Georgia access to health care. And I'm fighting to close the coverage gap to ensure that everybody, everywhere, no matter your zip code, has access to health care. Ms. Haynes, do we tend to see more medical debt in states like Georgia that have not expanded Medicaid than states that have expanded Medicaid?
That's absolutely correct. Households in the South, the region with the highest concentration of Black folks, carry more medical debt than other regions. This is exactly the region, too, where Medicaid expansion has not really happened. Of the 12 states that have not expanded Medicaid, 8 of them are in the South. That's left many people uninsured, particularly Black folks. Also, many of those southern states have a high percentage of for-profit hospitals, too, that are not subject to the charity care provisions of the ACA. But that said, the uninsured rate in the South is definitely connected to the lack of Medicaid expansion and connected to the increasing levels of medical debt in that region.
So you see a direct link between medical indebtedness in states like Georgia and its refusal to expand Medicaid?
Absolutely. Last stat, I believe, said that Georgia has the 4th highest or 3rd highest uninsured rate in the country. I have worked with clients directly in Georgia who are underinsured or uninsured facing medical debt and trying to figure out whether they need to file bankruptcy, trying to figure out how they can negotiate some sort of payment plan. It is definitely at crisis levels in states like Georgia.
Thank you. Medicaid expansion is something I'm focused on, and I'll keep pushing for that, but also capping the cost of prescription drugs would be helpful. According to the Kaiser Family Foundation, nearly 1 in 10 adults, or roughly 23 million people, owe medical debt, and as of 2020, American families collectively owed over $140 billion in medical debt. In Georgia, there's over $120 million in medical debt for over 108,000 folks. This is unacceptable. People should not have to choose between getting the prescription drugs they need and groceries. And this is why I introduced the Capping Prescription Drug Costs Act and the Affordable Insulin Now Act, which would cap out-of-pocket drug costs for Americans. Ms. Stewart, how would proposals that cap out-of-pocket drug costs like mine alleviate or help to alleviate the medical debt crisis in our country?
Thank you, Senator Warnock, and Community Catalyst supports both pieces of your legislation. Thank you for that. It is quite clear, based on the testimony of many people here, that it's underlying healthcare costs and people's inability to afford healthcare is a major driving factor. Kaiser Family Foundation also found that of people who have incurred medical bills that they cannot afford, 53% of them connect them to out-of-pocket prescription drug costs. So absolutely, efforts like the one that you are undertaking with your bills would help the underlying issues and help alleviate the burden of medical debt.
And Kaiser has done work, as I recall, in the past on the impact of Georgia's refusal to expand Medicaid on the Georgia economy. It's a drag on people's health care. It's a drag on the Georgia economy. Is that correct?
That's absolutely correct. There's many studies showing the connection between Medicaid expansion and improving overall economic well-being.
So we would do well to expand Medicaid in the 12 non-expansion states, or for us to have federal legislation to make sure that folks in those states can access a Medicaid-like program, and we would do well to cap the cost of prescription drugs, a net gain for the Georgia economy and for people's health care.
Absolutely, and it would help millions of people across the country.
Thank you so much.
Thank you.
Thank you, Senator Warnock. Senator Toomey is recognized.
Thank you, Mr. Chairman. Dr. Ippolito and Professor Hyman, let me address this question to the two of you, and I think you touched on this, but I just want to be clear. Can credit reporting and debt collection policies actually solve the underlying problem of high or unexpected medical debt, or would that require some healthcare policy change? Dr. Ippolito, you could go first.
Well, yeah. So I guess I'm going to echo something Professor Hyman said. But the challenge is that we're dealing with a clear symptom, right? This medical debt reflects something. It reflects something mechanical. A bill wasn't paid, obviously, but it reflects the fact that there was a bill that was potentially quite expensive, and then there was an inability to actually pay it. So the challenge is, if we're trying to address this through the banking system, if we're trying to address this through credit reporting changes, if we haven't actually changed the underlying risk that the lenders are responding to, for example, in that case, then the lenders are going to respond some other way. We have to assume they're going to respond to the fact that there's some risk that they can't observe. So clearly we're going to see some response, and that's where I worry more about the unintended consequences.
Professor Hyman?
Yeah, I would echo that. I think you should think separately about the bills that have already been accumulated versus the bills going forward. But I don't think changes in credit reporting practices meaningfully change the debt that is owed, although they may change the visibility of that debt. And if you don't do something about the cost of health care, you should expect future medical debt to compound itself rather than, as I said previously, addressing the root cause of the problem.
Right, and this is one of the reasons I'm concerned that the CFPB seems to be running point on this. They have no authority to make changes to healthcare policy. They don't have any particular expertise in healthcare policy, and they're certainly not going to address the underlying problems. Let's talk a little bit, if we could, about the effects of suppressing information. Now, I understand that there might be categories of medical debt that may not be particularly predictive about a person's credit worthiness. I don't know, something like hospitalization for a car accident is something that's obviously completely involuntary, extremely unusual, could be very expensive if you don't have insurance. On the other hand, I think somebody, and Dr. Ippolito might have been you, pointed out that a very large majority of unpaid medical debt is under $500, is a few $100s, which seems to suggest it's something closer to a more routine medical expense. And failure to pay that, maybe that tells us something different about, that maybe it has a different predictive value with respect to creditworthiness. Could you talk a little bit about the differences between different kinds of medical debt in terms of their predictive value and the unintended consequences that could emerge if that which has some predictive value is suppressed and is simply obscured to creditors?
Yeah, so I think there's two things there. So the first thing is you point to one of the big challenges when you look at the data on this topic is that the distribution of medical debt often doesn't look like what you're expecting, because I think so many of us are thinking car accident. It's the unavoidable thing that generates a huge bill. It's easy to understand how that generates a lot of debt. But that really is atypical when you look at the credit profiles at the CFPB, for example.
Atypical.
That's atypical. Yep. Yes, that's right. The typical experience is the median medical collection is $300, $310, I believe, in 2020. $310 can be generated in a lot of healthcare interactions that aren't the catastrophic situation. And so I think your question speaks to the way I think about this topic, which is that we're seeing something that's an interaction between two things. One is there's a healthcare component, obviously, but there's also a personal finance component too. And so if you're seeing $300 bills, $200 bills, $100 bills not getting paid, it's not completely obvious to me that the answer is, well, it's obviously a healthcare problem per se, obviously the cost point notwithstanding. It seems to me that we have a broader personal finance problem that, again, suppressing information on a credit panel isn't going to get rid of that risk. It's just going to hide the risk. And we know people are going to respond because we see it in other markets. And so that's the core tension I see.
Professor Hyman, did you want to comment on that?
Yeah, I'd just add, I think it's hard to infer much about the creditworthiness of a particular individual simply based on the size of the medical bill that they received, especially if you're looking at bills in isolation when, you know, a single encounter with the healthcare system can result in multiple bills, each of which might be in collection. And so the dollar amount is informative of the distribution, but it doesn't tell you that much about whether there's been an income shock or ability to repay has been affected or not. You need more information on that.
Thank you. Thanks, Mr. Chairman.
Senator Warren of Massachusetts is recognized.
Thank you, Mr. Chairman. So this is an important hearing. Medical debt is the most common form of debt on consumer credit records. It represents about 60% of all consumer debts listed on credit reports, totals as much as $140 billion. And for the nearly 1 in 5 Americans with medical debt in collections, who are, by the way, disproportionately Black and Hispanic, it means facing aggressive and often predatory collection practices that can ruin your credit, garnish your wages, and drive you into bankruptcy. It also means that when it damages your credit score, it drives up costs for mortgages, credit cards, and other financial products. Now, medical providers often outsource their debt collection to other businesses. In recent years, one of the big players to pop up in this space is, surprise, surprise, private equity. Giant private equity firms have slipped their tentacles across the healthcare industry, spending about $750 billion over the last decade to buy up everything from hospitals to ambulances to the companies that bill patients and track them down to collect those debts. Ms. Haynes, you are an expert on medical debt collection practices and their impact on families. So let me ask you, how would you characterize private equity's collection practices? Does it have a good track record of following the law and doing right by consumers?
Private equity hospitals and debt collection are as much a part of the problem in the medical debt crisis as the other players. They are very aggressive in their collection practices. They file lawsuits against patients. They harass them via phone, report their debt to CRAs, even when the debt isn't owed. They are as big a player in the medical debt crisis as any other players in this crisis. And I should say that these aggressive debt collection practices involving liens on homes are particularly damaging. Hospitals, once they actually seek a lien on a home, it can really damage the person's current asset value and their housing stability ultimately.
Right. And I just want to underline one of the phrases you used in there, including when the debt is not even owed.
Yes.
I'd like to know how much of those $300 medical bills are not actually even owed. But debt collection is an ideal business for private equity because their whole business model rests on squeezing companies and people dry. The standard playbook is to buy up a company by loading it up with debt, squeeze the company to extract profits, then take the money and run after a few years. In the medical debt collection business, that means doing whatever it takes to collect as much money as possible from patients and do it as fast as they can. So it is no wonder that private equity is gobbling up medical debt collection firms right and left, rolling them up into consolidated debt collection giants. In recent years, private equity has been behind as much as 1/3 of the acquisitions of these companies. Ms. Stewart, as the executive director of Community Catalyst, a consumer health advocacy center headquartered in Boston, you've worked to protect consumers across the country from predatory medical debt collections. In your view, is the consolidation of medical debt collectors under private equity ownership likely to be in consumers' best interests?
Senator, as you noted, the objective of private equity is, generally speaking, to make big profit and to attract investors. In the world of healthcare delivery, private equity has usually meant rising healthcare costs, particularly for people. So if past practice is a predictor of the future, it is highly unlikely that private equity consolidating medical collection practices is going to be a good thing for people.
Thank you. You know, medical debt is one of the biggest threats to families' financial security, and I'm glad that the CFPB has taken steps to reduce this risk, including by pressuring the big 3 credit reporting agencies to clear up to 70% of medical debt from credit reports. This is going to boost scores for millions of Americans. But we also need to crack down on the role that Wall Street private equity firms are playing in the medical debt crisis, whether that's providing care, billing, or debt collection. My Stop Wall Street Looting Act would better align incentives between private equity and the companies they take over in order to protect patients and their lives, financial and otherwise, and make sure that they aren't ruined by corporate greed. So I think this is an area we need to work on. Thank you, Mr. Chairman.
Thank you, Senator Warren. Senator Tillis from North Carolina is recognized.
Thank you, Mr. Chairman. Thanks to all the witnesses for being here. I know there are some people that think the CFPB wading into this space makes sense. I'm not one of them. I think we've seen their expansion of influence through the hostile takeover of the FDIC by the director. Now we see them wanting to move into the healthcare space. And I do think it's a problem we need to address. I just don't necessarily think that's purview of this committee to deal with it. If you listen to Senator Warnock, virtually every solution he had to this problem dealt with committee subject matter outside of our jurisdiction. Dr. Ippolito and Professor Hyman, Senator Toomey mentioned a few statistics. I just want to make sure that I'm right and see if there are any other indicators we should be following. About a little bit less than 1% medical debt is in collections. Is that right?
I'm not sure what percent of medical debt in total.
Yeah, I think it's somewhere around 0.93% of all household debt, and only about 8% of that ultimately gets collected. Now, one number that I am curious about is that medical debt has reduced substantially, about 40% since 2009. You would logically think some of that tracks with the implementation of the Affordable Care Act and expansion of Medicaid. Are there any other things that would have potentially contributed to the reduction in medical debt over that period of time?
Well, I mean, broadly speaking, I'm sure that the improved economy from about 2010 to now has to have improved part of what we're seeing there, and other outcomes on credit reports.
Professor Hyman, when you were talking about if this credit reporting is no longer taken into account as a predictive indicator, I think you said something to the effect that they would respond, that lenders would somehow have to respond to that risk. What would that look like? Give me some examples of unintended consequences.
So look, it's hard to make predictions, especially about the future. But to quote Yogi Berra, or maybe it was Mark Twain, but in any event, I, as I indicated in my written testimony, I would expect some increase in credit scores to happen. But the question would be whether credit agencies would make adjustments, as Dr. Ippolito indicated.
Setting the bar for what may or may not be a good or...
Exactly. Basically, either modifying the formula to come up with numbers that actually matched more closely ability to repay, or moving the bar for what counted a good risk versus a bad risk. With my healthcare hat on, though, I would point out that there are potential follow-on consequences within the healthcare system. So healthcare providers may become less willing to take patients that are unable to pay in full at the time of service. And I would also expect, as I indicated in my written testimony, some increased consolidation because larger providers are better able to weather this storm than a small or individual practice might be.
What other significant potential unintended consequences can come from addressing the symptom versus some of the underlying problems that you mentioned in your opening testimony?
Yeah, I apologize for not addressing that. The other problem, of course, is this is a feedback loop indicating the problems with the American healthcare system, and it's no different than turning off the fire alarm. The fire's still going. You just no longer have the same evidence of the underlying problem, and you may not feel the same urgency to put the fire out.
Ms. Haynes, I was more curious than anything. You mentioned that that the Black and Hispanic community is disproportionately hit by this. I think you also mentioned there are 2 times, or they're likely to be contacted twice as many times as a white person who may be in medical debt. Have you looked at it along socioeconomic lines? Is there much disparity, for example, between Black, Hispanic, and white poor family? So, do you understand the question?
Mm-hmm. Yeah, that's actually a really fantastic question. It's covered in the report that is attached to my testimony. But the data shows that in zip codes that are predominantly Black, no matter income, they're more likely to be contacted by debt collectors than white zip codes and non-black zip codes. So actually the data does show that across incomes, black folks are still more likely to be contacted by debt collectors.
Okay. Thank you. Thank you, Mr. Chair.
Thank you, Senator Tillis. I will ask my questions now. Start with Ms. King. And in May 2020, you first received your alarmingly high bill. I know you've said some of this in your testimony of $69,000 from the nursing home that cared for your mother. In October 2020, shortly after her passing, the nursing home sued you for close to $80,000. What impact did this enormous amount of medical debt have on your life? Did you imagine you'd ever be free of this?
And that amount, I could not. It was just really more than I could take in at that time. I was grieving, or my mom had just passed, and I was just trying to figure it all out. Like, how could they do this? I said I would not be responsible, and how am I getting sued? So I had no idea how I would handle that, how I would take care of paying that amount, and what were they going to do to me? So no, I had no idea. Like, it was unbelievable. I felt terrible, and it was tough. It was ridiculously tough.
And fortunately, you found legal services, and they found you.
I found legal services, and they helped me.
And Cleveland has a particularly good legal services,
They have
legal aid society. So
very much so. They are amazing.
thank you. Ms. Stewart, as we point out, medical debt doesn't mean someone is a credit risk. It means they got sick. Accidents and sickness, as all 5 of our witnesses pointed out, can happen to anyone at any time, yet people with medical debt are harassed and often made to feel like a burden to society. Obviously, medical debt isn't the fault of the person who gets sick. Would you say that my question is this, would you say that our financial system treats medical debt like a moral failing?
Yes, I would say that our financial system treats it as an individual moral failing, when really it's a failing of the financial system and the health system taken together. As we discussed during this hearing so far, the healthcare system is not regulated in terms of healthcare cost, and people are bearing the brunt of rising costs, being forced to pay higher deductibles, higher co-insurance, and the financial system, in terms of billing and collection around medical debt, doesn't take any of that into account, which is why we're really grateful at Community Catalyst that you're holding hearings like this to have conversations about systemic reforms that need to take place both in the financial system sector as well as the health system sector.
Thank you, Mr. My last question, Ms. Haynes. Under pressure, as you know, Equifax and TransUnion Experian just took an important step to wipe 70% of medical debt off credit reports. These changes will help the financial lives of millions of consumers. However, that means 30% is left, obviously. You said in the past that medical debt is not predictive of credit risk. So since medical debt is not a good indicator of credit risk, should medical debt even be part of a credit report? Should all medical debt be prohibited from being reported?
Yes, as I suggested in my recommendations in my testimony, ideally we should end the practice of turning over any debt to debt collectors, considering how involuntary and unpredictable debt from medical emergencies tends to be. And I should also add that the credit bureaus and the change that they made, while it is wonderful, there's a couple of categories of medical debt that's going to be removed from credit reports. A lot will still remain on people's credit reports. So debts of less than $500, for instance, will be removed. Debt that has been paid off. And that'll help 15% of Americans. But if you look at the stats from the Urban Institute, the average medical debt Americans have in collections is $797, $854 for non-white communities. So those individuals will still be left on the hook and still see those debts in their credit histories.
Thank you. With these changes to how medical debt is reported, I think it's worth considering what next potential steps the CFPB and others might take to further lighten the medical debt burden. Senator Ossoff is from Georgia, is recognized from his office.
I want to extend in particular a warm welcome to you, Ms. Haynes. Thank you for joining us and representing the state of Georgia. I'd like to begin with you as well and ask you, Ms. Haynes, based upon your knowledge And then I'm going to turn to Professor Hyman with the same question. How does the American experience of incurring massive debt because of a medical emergency, because you or a family member needs a medical procedure, how does that compare with the experience of folks in other wealthy countries around the world? Ms. Haynes, please.
Yes. Well, as I noted in my testimony, in terms of the recommendations, enacting a publicly funded universal national single payer plan administered at the state and local levels would go a long way towards remedying this problem. In various countries outside of the United States, they do have some version of a public option of public payer system. So I won't speak to that any more detail because I'd have to get back to you about how that would actually look. But medical debt in this country is a uniquely American problem, and we need to address it as it stands currently.
Professor Hyman, in the course of your research, whether or not you've undertaken a formal comparative analysis with other countries, nevertheless, what is your impression, your reaction to the same question, how the American experience of medical debt contrasts with the experience of folks in other OECD or industrialized advanced countries?
Thank you, Senator, for the question. That's not been the primary focus of my research, but my sense, based on having done this for quite a while, is that the United States is an outlier, to say the least, relative to other countries in the cost of its healthcare system, which has predictable consequences for medical debt. Other countries vary in their delivery systems as well as their financing, but the United States is nonetheless an outlier.
Thank you. Ms. Haynes, I spoke with a fellow Georgian named Felicia from Hogansville, who took care of her father after he recently suffered a stroke. The family faced steep medical bills. The impact of that debt has lowered her credit score and imposed a huge burden on the family. As a result, she was unable to take out a loan that was necessary for some home repairs. This is, of course, not an uncommon story. Ms. Haynes, folks don't choose to incur medical expenses for the most part, correct?
That is correct. Medical debt tends to be very unpredictable and involuntary. It usually forces people to drive up their credit on credit cards, taking out personal loans. Medical debt really can throw people into a real financial tailspin.
And as a fellow Georgian, Ms. Haynes, you are well familiar with the ongoing saga of the state of Georgia's refusal to expand Medicaid under the Affordable Care Act, one of just 12 states that's made that decision. 80% of medical debt is held by households with zero or negative net worth. How could Medicaid expansion in the state of Georgia, which Senator Reverend Warnock and I have fought for, we delivered resources to make it an even better deal for the state of Georgia. Georgians are already paying federal taxes at the same level as folks in other states, but not getting this investment in public health, forcing low-income and middle-income Georgians into the emergency room instead of into preventative health care. Ms. Haynes, in your opinion, what would be the impact of Medicaid expansion in Georgia on the burden of medical debt that is faced by so many of our fellow Georgians?
Yeah, thank you very much for that question. Georgia, as you know, has one of the highest uninsured rates in the country. It disparately impacts Black and Latina families in Georgia. Expanding Medicaid would not only help in terms of the rural hospital closures that we've seen in Georgia that are directly connected to the lack of Medicaid expansion, but it would also help reduce the medical debt crisis that is facing many Black and Latina Georgian families by making sure that they're not lost within the coverage gap.
Thank you, Ms. Haynes. And Ms. Stewart, as has been discussed, Equifax, Experian, TransUnion recently announced changes to the way that they score medical debt. As I understand it now, medical collection debt under $500 won't appear on consumer credit reports. The average amount of medical debt, according to my staff's research, is approximately $2,400 for those who are carrying it. So, Ms. Stewart, how will the credit reporting agencies announcement of this policy change impact individuals who have more than $500 of medical debt?
Senator. Oh, thank you, Senator. Well, for people who have debt more than $500, they will have an extra year to resolve the debt. So that's the good news of the policy. But beyond that, people with debt over $500, it would not be removed from their credit report, and that is something that we would encourage CFPB to pursue and explore.
Thank you all for your well-informed and concise questions. And Mr. Chairman, thank you for holding this hearing. I'll just close with this note. It is a travesty that millions of Americans suffer not just from illness that they're unable to treat or prevent in the way that most of us would want and expect because they can't get health insurance, but then the burden of debt at these moments of stress and crisis for their families. We have widespread medical debt in this country. We have children with school lunch debt in this country. We have to stop burdening working people across the United States with debt for the necessaries of life like food and health care. And I thank you, Mr. Chairman, for convening this hearing to shine a light on this issue.
Thanks, Senator Ossoff. Senator Cortez Masto from Nevada is recognized.
Thank you, Mr. Chairman. Thank you for holding this important hearing, and thank you to the panelists for joining us this morning. One issue I want to raise here is the issue of medical debt in Indian country. For generations, the federal government has had a trust and treaty responsibility to provide care to sovereign tribal nations, but the volume of medical debt across tribal communities is evidence that we have fallen well short of meeting those obligations. In 2019, the New York Times report found that Indian health services declined to pay medical bills for more than 500,000 patients, saddling them with more than $2 billion in medical debt over the preceding 3 years. Ms. Stewart and Ms. Hayes, how will these changes in reporting affect Native Americans? And I'll start with Ms. Haynes.
Unfortunately, I can't speak to that particular issue, but if we're talking about federally held debt, you may be aware of some of the changes related to federally held medical debt recently that may go a long way towards helping consumers avoid some of the credit downfall of medical debt.
Thank you. Ms. Stewart?
I would agree with Ms. Haynes, and just to highlight that one of the big issues with respect to medical debt and its impact on Native Americans is a lack of data, and it's something that Community Catalyst is really focused on making sure that there is more investment in disaggregated data so there's much more clarity about the impact on Native American populations.
Thank you, because I sit on the Senate Indian Affairs Committee, and this is one area, and you just touched on, is the lack of data. Mm-hmm. And because of the lack of data, we're missing out on important services to our communities, including our tribal communities across the country. And we really have to start focusing on those that are being left behind. And so let me jump to another area, which is the lack of communication I find here in some of this and important information that needs to get out there that isn't at times. In the recent CFPB report, it was illuminating because it said that 50% of Black respondents in a survey did not know that hospitals provide free and reduced cost care for low-income patients. Now, do we know what the level of awareness of these programs is among Spanish-speaking and other non-English-speaking communities? I mean, this is a travesty. And let me just stop there and ask maybe Ms. King or Ms. Stewart or Ms. Hayes. I'm concerned that the information's not getting out there. And we have a report here showing that members of our Black community are getting it. What about those that have a language barrier? How do we ensure that they're getting access to this information that is going to be important for their health?
I'll start, Senator. Well, first of all, there are no requirements that hospitals, including nonprofit hospitals that are 501c3 nonprofit organizations, proactively screen people for financial assistance programs. There are responsibilities to make information publicly available, but for many, many people, they report that they had no awareness that they were eligible for financial assistance. For people who, for English is not their primary language and need language assistance, that is really a very critical issue. And there's, you can imagine how that issue is expounded when somebody has a language barrier. So it's deeply concerning overall, and especially concerning for people who face language barriers.
And what should we be doing about it? What can Congress do about this to make sure this information gets out there?
Well, there could be changes to the nonprofit community benefit standards to require nonprofit hospitals to proactively screen people for financial assistance programs prior to billing them. In addition, there could be financial support for consumer assistance programs and other community-based organizations who could be available with resources to offer that kind of assistance to people.
Thank you. Yes, please.
Yeah, I would just add that the Affordable Care Act included requirements for nonprofit community hospitals to develop a plan and report on the plan, but it did not include parallel requirements to disclose to patients, along with all the other things that they do disclose to patients. Hey, we have a charity care program, and here are the details and how you should apply for it. So you could do that with either legislation or regulation, it seems to me, as a condition of participation.
Thank you. Yes, Ms. Haynes.
And I just wanted to add to those great comments as well, that in addition to improving the FAP so that folks are required to screen patients before collecting, there's no right of action that patients have currently under the Affordable Care Act to enforce the FAP requirements. So allowing patients to actually enforce state and federal FAP laws in court to hold violating hospitals liable would also go a long way towards improving this charity care.
Thank you. Thank you, Mr. Chairman.
Thank you, Senator Cortez Masto. We'll wrap the hearing up. Thank you, the five of you, for being here. As Senator Toomey's charts pointed out, the Affordable Care Act, especially its Medicaid expansion, not only improved health of Americans, it's also improved their financial health as well. Thanks to the ACA, states that expanded Medicaid programs, we know Georgia is an exception, but states that expanded Medicaid programs saw medical debt fall by 44%. Think of that, almost in half. I would add parenthetically, I know Senator Cortez Masto cares so much about this, the implementation of the child tax credit also dropped the poverty rate by about that number, 40% for America's children. The ACA and Medicaid expansion help reduce medical debt. Much more needs to be done. I look forward to working with colleagues in Congress and at the CFPB to reduce medical debt, including by creating a medical debt ombudsman. Americans should be able to focus on their health, not worry about their financial health. And as Ms. King pointed out so well, those particularly difficult times. To highlight the need for congressional action, I would like to submit for the record 3 testimonials from Mindy Hedges of Ohio, from Penelope Wingard of Senator Tillis' state, from Sloan Westlow from Senator Toomey's state. Without objection, so ordered. Thanks for the witnesses. For senators who wish to submit questions, these questions are due 1 week from today, on Tuesday, April 5th, to the witnesses. To the 5 of you, if you get questions submitted, please submit your response for the record within 45 days from the day you receive them. The hearing is adjourned.